As you know, it's my great honor to present Dr. Jimmy Volmink, the Dean of Medicine at Stellenbosch University, who is going to lead the next panel on health disparities. Jimmy.
Well, good morning again. I don't know how anybody can speak after what we just I'm sitting there and I don't know what to say. It was wonderful. Thank you so much, Stephen, for that fantastic presentation. So in this second plenary, we continue focusing on health disparities, a time for action. We will continue to look at the impact that disparities are having on the people of the world, but more importantly, what can be done to address those disparities. We've agreed on the following plan for the plenary, which I want to share with you. I've been asked to make some introductory remarks and to provide a perspective from Africa. Thereafter, we will have Patty Garcia. Patty is professor at the School of Public Health at Cayetano Heredia University in Lima, Peru. She is a former Minister of Health of Peru and Dean of the School of Public Health at UPCH, as well as a former chief of the Peruvian National Institute of Health. Thereafter, we will once again have Stephen Lewis providing an input. As you already know, he's the co-founder and co-director of AIDS Free World. And then finally, we will have an input from Mary Bassett. Mary is not here yet. She will still arrive, I'm told. And so she will join us to provide the last input. Mary, just by introduction, is the Commissioner of Health for New York City. She lived in Zimbabwe for nearly 20 years and previously was the Program Director for the African Health Initiative and the Child Wellbeing Program at the Doris Duke Charitable Foundation. Each of the speakers will be given about 10 to 12 minutes, so we will have plenty of time left then for Q&A and for discussion and participation from the audience. So that is generally the plan. And so I'm going to ask the panelists that are here, Stephen and Patty, to please join me up front if they can. Thank you. All right, so I have the great misfortune of having to say something after Stephen Lewis being the first person to do so, and I'll try my best. Let me start by quoting some work from Goran Thurborn, who is Professor of Sociology at Cambridge University. Goran Thurborn has described three types of inequality. Resource inequality, which refers to unequal distribution of access to capitals, such as money, education, cultural assets, social contact, and power. Resource inequality also applies to unequal access to environmental resources, such as water, sanitation, and health and social services. Secondly, he talks about existential inequality, referring here to unequal allocation of autonomy, freedom, dignity, respect, self-actualization, and so forth, pointing out that such inequalities are often associated with patriarchy, institutionalized racism, and discrimination based on sexual orientation or disability. And the third type of inequality is vital inequality, whereby he refers to unequal life chances measured using indicators such as child growth and development, mortality, life expectancy, hunger, and malnutrition. Thurborn points out that these three types of inequality are usually interlinked. Thus, when we think about health disparities, it is important to recognize, especially if the aim is to find solutions, that at the root of health inequalities, we will usually find inequalities in the other two domains. A couple of years ago, the World Bank proudly declared that just over 1 billion people have been lifted out of extreme poverty since 1990. When one thinks about this, I think one should come to the conclusion that this is not really such a great achievement. The prevalence of extreme poverty, which is defined as living on about $2 a day or less, is a low bar for measuring human progress. Extreme poverty, quote, is a condition characterized by severe deprivation of basic human needs, including food, safe drinking water, sanitation facilities, health, shelter, education, and information. No one lives on $2 a day. They only die. And there is still almost 1 billion people in the world today who exist on this level of income. Would an income of $10 a day lead to a life much less miserable or precarious? I doubt it. And yet, a whopping 70% of the global population falls into this category, with no noticeable decline in this income bracket in recent decades. It is therefore right that the United Nations targets the eradication of poverty as one of the Sustainable Development Goals to be achieved by 2030. But it is also appropriate that the reduction of income inequality is included in the SDGs. We have already heard very eloquently from Stephen Lewis about the obscene levels to which income inequality has grown in recent years. Sub-Saharan Africa, along with Brazil and the Middle East, has among the highest rates of inequality in the world. In 2016, the share of the national income in Sub-Saharan Africa going to the top 10% was 54%. This is higher than the corresponding figures for the United States and Canada, Russia, China, or Europe. Now, complete long-term data are unfortunately not available for most of the countries in Sub-Saharan Africa. So let me give you some figures for South Africa, the country where I live, where we do have reliable data. Income inequality has always been pronounced in South Africa. But what we know now is that the share of income going to the top earners has increased significantly since the fall of statutory apartheid in 1994. By 2014, the top 10% in South Africa received around 2/3 of the national income, and the top 1% had captured 20% of the national income. In the same year, the richest 10%, who are predominantly white on account of the legacy of apartheid, enjoyed an income comparable to the same group in France, Spain, or Italy. By contrast, incomes of the bottom 90% in South Africa were similar to those of people in low-income African countries. These levels of inequality are quite extraordinary on a global level. Does extreme inequality really matter? Evidence suggests that it matters a great deal. Leading scholars of inequality, such as Joseph Stiglitz, Thomas Piketty, Michael Marmot, and Wilkinson and Pickett, to name only a few, have all concluded that inequality harms society in very real ways. Severe income inequality undermines democracy. When such inequality exists, the wealthy elite often corrupts or captures democratic structures and processes, thereby denying the majority the anticipated benefits of democracy. Severe inequality also threatens social cohesion and stability because people who are left behind become dispirited and lose faith in the possibility of achieving a better future for themselves and for their children. Thirdly, income inequality is, as we've already seen, is an important driver of disparities in health, education, and life chances. And finally, extreme inequality inhibits economic growth, thereby retarding poverty alleviation efforts. In the remaining few minutes at my disposal, I will briefly turn my attention to the following question: how can the prevailing health disparities on the African continent be addressed? And to answer this question, I will draw on the recently published Lancet Commission on the Future of Health in Sub-Saharan Africa, entitled "The Path to Longer and Healthier Lives for All Africans by 2030. The Commission began by formulating the following vision to guide its work. Quote, "By 2030, Africans should have the same opportunities for long and healthy lives that the new technologies, well-functioning health systems, and good governance offer people living on other continents." Now, I have to admit that when I read this, I was a little discouraged. The title of the paper talked about improving health for all Africans, suggesting the emphasis on health equity. Yet the vision appeared to be restricted to a focus on tackling health service and systems issues. This bias notwithstanding, the Commission did make a sincere attempt to discuss broader concerns, and I will now provide you with a brief synopsis of its recommendations. 8 crucial areas for action are identified in the Commission's report. Number 1, establishing people-centered health systems, including universal health coverage. 2, improving health stewardship through strategic leadership, multi-stakeholder engagement, and greater accountability. Thirdly, ensuring sustainable financing for health, including financing of universal health coverage. 4, access to essential commodities such as drugs, vaccines, and medical devices. 5, strengthening health systems and improving epidemic preparedness. 6, enhancing health workforce development through improved training, retention, and deployment, and by promoting social accountability of training institutions. 7, investing in research and institutional strengthening, and finally, embracing innovation such as new technologies to overcome health workforce constraints. Now, particularly pertinent to addressing health equity, or health inequity rather, is the issue of universal health coverage, mentioned by Dr. Tedros earlier, which is currently on the agenda of many African countries. The Commission stresses the importance of having a clear focus on prevention and health promotion, and not only on curative care. Critically, in the view of this Commission, the universal health coverage should target the improvement of health outcomes and not only healthcare delivery and quality. And finally, it says the health system must promote the values of respect, dignity, and compassion. The report also includes a discussion on the need to directly address the social determinants of health through actions outside of the healthcare system and strengthened linkages between health and other systems. It emphasizes the importance of attending to socioeconomic, cultural, and environmental conditions throughout the life cycle and notes specific African examples of where this is being done. For instance, it mentions initiatives such as the promotion of school enrollment for girls through cash transfers, ensuring schools and homes have adequate toilet facilities, particularly for girls and women, the provision of social protection to older people, children, and the disabled, and the promotion of anti-discrimination campaigns as part of the HIV/AIDS response. All of these areas for action mentioned in the report are laudable, and many of them are already being implemented in some form in Africa and other economically less developed regions of the world. However, in my view, these measures alone will not be sufficient to improve health and reduce inequity in the long term. Like much of the global health literature, the Lancet Commission's report largely ignores the economic and political values and forces that shape the ideological, intellectual, and research frameworks underpinning health disparities. I believe the critical question for us as the global health community is this: how willing are we to confront the neoliberal global economic system driving so much of the health and social challenges we see in the world today? This is the system that has led to the rise in power of transnational corporations and global finance, which have the effect of undermining national sovereignty and depriving the poor of the benefits of democracy. This is the system that helps sustain poverty and inequality, that weakens our healthcare systems, and that contributes to internecine conflict and displacement of people and the generation of large numbers of refugees. And this is the system that drives the tsunami of non-communicable diseases and contributes to climate change and environmental degradation through overconsumption, which disproportionately affect the poor of the world. Technology and technocratic interventions alone are therefore not enough to ensure health and equity in the long term. What is needed is to end, or at least significantly reduce, unfair distribution of resources and power, and the structural violence and injustices which underpin poverty and inequality in our world. Let us redouble our efforts to achieve this vision. Thank you. Our next input is from Patty Garcia. Thank you, Patty.
Well, I think that we are all moved, but it is time for action. And I want to set up the stage of the kind of things that we can do. And as Keith asked me, try to bring some, or at least one example. I wanted to give you more, but I have only 10 minutes, so I'm going to focus. And let us start. Can I move this? Excellent. I come from Latin America. How many people from Latin America working and suffering in Latin America are here? Can you raise your hands? Thank you. At least here we are. Latin America is a region that, despite significant social and economic changes over the past 50 years, remains the most unequal region in the world. Indeed, Latin America is 19% more unequal than sub-Saharan Africa. And it's 35 37% more unequal than East Asia, and it is 65% more unequal than any of the developed countries. And those inequalities are affecting the distribution of resources and also of social opportunities. And that causes high levels of poverty, deterioration of environment, that blocks the development of human capital, and that causes institutional weakness and corruption. And all those things affect health and cause disparities. And I come from this little orange country, Peru, in the middle of South America. And Peru is one of the most unequal countries in Latin America, said by the World Bank. We have lots of problems related to health. And today, I just want to focus on one that affects women, poor women, women with poor education, women in rural areas, and it is cervical cancer. And the facts, probably you all know. Cervical cancer is the third most common frequent cancer in women. It's caused by human papillomavirus, but in Peru, is the #1 cancer affecting women and the #1 killing women. And that is because, of course, we have a lot of HPV, but having counted them, very few women end up having a pap smear, although the system is there, and we have pap smears through the public health services completely for free. The other problem that we have is that the quality of the pap smears is pretty poor, so the sensitivity to detect cancer is low. And in Peru, every 5 hours, a woman dies from cervical cancer. However, and that's why I want to bring this positive thing, there are new ways of detecting the presence of a virus, which could help us to detect the problem before cancer occurs. And we all know there are new molecular tests that are around and can detect the presence of HPV in the cervix and in the vagina. And they could be done by women in the comfort of their house, so like self-administered swabs. So there is hope. And with funding from Grand Challenges Canada, we decided to try to put together, a project that we call HOPE, Improving Women's Health Using Molecular Self-Testing for Screening of Human Papillomavirus. And the concept was relatively simple. We not only need technology, and we were talking about technology as new molecular tests, but also technology as information technology, but we need humans, women. So we decided, what about if we identify women in the community and we train them? They could become champions, and they could provide, reaching other women, these kits for screening for cervical cancer. So these will become community health agents. I don't use the word workers because they are not paid. They are completely volunteers. And we call them the Hope Ladies. They could go, reach women, and then find women that will self-test at home. The tests could be taken to a collection site that could be open 24/7. For the ones that are around my age, do you remember those boxes of Blockbuster? We had them in Peru at some point. So you could go at any time of the day and just leave it there. And the technology allows you to do that because these tests are very stable at room temperature, even at high temperatures, and for several months. Then the technology is easy, so it can be done at a health center. It can be processed, and the results can be given through SMS messages, so women, if needed, will have colposcopy, and we can have a new model for cervical cancer screening. And that's what we call HOPE. And actually, we got funding, and we decided to do this in a shanty town called Ventanilla, Callao, which is just 30 minutes from the Lima airport. And I'm sure that none of you that had been in Peru had ever looked backwards, but there is there, in the middle of the desert. No water, no electricity, close to the airport, in a city that has about 10 million people. This community has about 2 million people. And we decided to work there. The first challenge was, how can we identify potential women champions? We went walking in the communities, left posters with numbers to see if there was women that was interested in learning about cervical cancer and be part of a new era trying to control cancer. We went to the markets. We went to the schools where women are with their kids, and they start calling us. So we had a big group of women that were interested, and we started to do some workshops near the community. And they start learning about cancer, about cell collection of samples, and they were the ones, the very first ones that were tested. And then, when we were asking them, how are we going to reach women? Well, they brought this great idea. They said, well, we have to do it in the markets, because that's where we spent a long time. But we wish for something, and I asked, why? What is your wish? Well, we should have some type of tool that we can take to the market, so while we are buying things, we can also reach women and teach them. Something like a bag that can help us to do the reaching. And ta-da! So we imagine something as simple as this and test it with them. So they could go to the market, and then once they found the women, they could say, hey, would you like to learn about cervical cancer and how is your body? And you can imagine, I mean, with this is how you are in the outside, and this is how you are in the inside. And this was the kit, an envelope with a barcoding, and inside we have exactly the brush, right? And women could, even in the market, teach other women to do the self-testing. So all the women, start doing the role-playing, and as you can see, they are laughing there because this really worked. It was a simple thing to reach other women. And we certified all these HOPE ladies to start doing the reaching of other women. They start going out and then distributing these kits. And then we started seeing women bringing their samples to these boxes, these collection boxes. We created a system to collect the samples once a week with this motorcycle, going to the three collection points, bringing them to the lab. The results were processed, and then we were sending results and reminders through SMS messages. When the results were negative, a woman was HPV negative, we will tell them, congratulations, you need to keep taking care of your health. And we were strengthening the role of the health center near their community. And for the ones that were positive, we were telling them that we were having the results, and that in the next message, we were going to give them the date and time for their appointment. And we were giving them also reminders. Although this system was supposed to be one way, we started receiving SMS messages saying, like, God bless you, oh, I'm so glad, what can I do next? And women really, really were involved in this. So I'm not going to go too far about the results, but let me tell you, this was supposed to be a one-year project. And we started in mid-2015, ended the collection in 2016, and I became Minister of Health around July 2016. We were supposed to reach, because the budget was very little, this was a proof of concept, we were supposed to reach about 1,500 women, but we stretched, and we were able to go for the 2,000s. So we were leaving the kids with the women, but and everybody was concerned that women were not going to take the samples or bring them to the boxes. But actually, we found in the collection samples more than 96% of the samples. And we know that some people didn't bring it back because they were concerned that it took more than a week, for example. So we know how we can improve the messages so everybody will bring their samples, because everybody was interested. And we had about 12% of abnormal biopsies. I mean, high-grade cancer, high-grade lesions and cancer. And all of them were on HPV-positive women. We also have a subsample of HPV-negative women that were tested just to find out how the test worked, and it worked very well. So, what are the learning points? For the more than 2,000 women that we screened, 2/3 have never, ever had a pap smear. That means that we can really improve coverage. Women love self-testing. They can do it alone in their houses without anybody else there. And women they are scared about going and exposing themselves to health centers, and also sometimes husbands don't allow them to do that. The collection sites open 24/7 are critical, and the technology is very much appreciated. They like the idea of molecular and new tests. Pap smear is kind of an old-fashioned thing. And getting results by SMS messages was really, really popular. In 2017, as a Minister of Health, we launched the new national guidelines in Peru for cancer that included HPV molecular testing for the very first time, and also we included self-testing as a way of doing screening in cervical cancer, as a new plan for the control. So we have started already in the northern part of Peru, just a couple of months ago, in Tumbes, and now we have more than 5,000 women that have been screened. But not only screened, but they are followed, so we're strengthening the health services. I said we because I still feel that I'm there, okay? But I'm not a minister anymore since September. And there have been 2 other ministers following me, so I'm trying to back them to continue to do this. Anyway, but we notice also that there are still disparities because we have women that can access the national comprehensive insurance system when they are very poor. We have women that have private insurance, but we have women that have nothing because they are informal or they are not as poor as to have the comprehensive insurance. So we're planning a new social business model for women not covered and other women that might be interested. And so basically the idea is to sell the HPV tests, okay, that will help to support the health ministry for the program, and also to start thinking about giving incentives to these HOPE ladies. The HOPE ladies got empowered. They were not receiving any money, but we could help them within the community to do a better job. So this idea is in the final list for funding for Grand Challenges Canada, but we still need matching funds. So just in case, we're looking for angel investors and funding agencies, because I think we need to have different ways to approach problems. So just to wrap up, new technologies, and in this case I'm giving you just an example, HPV molecular testing, and the use of cellular phones can improve cervical cancer control. But they can be used also to avoid or to jump over the disparities. Self-testing improves access, and I have been just 2 days ago in Geneva at a meeting at WHO where we are starting to talk about the user-initiated interventions, and I'm so happy. It's UII, or in Spanish, UI, which is great because we're starting to change the power from just health providers into the hands of people, okay? And especially for reproductive health, and this is starting from the Department of Reproductive Health, that's another way we can start breaking disparities. The HOPE ladies, that are these women health agents or community health agents that are leaders and become leaders with the training, are an incredible, powerful tool to reach not only women, but to reach families. And this is something that in Latin America, in several countries we have been doing, but we have to do more. And I suggest that you start doing that in the rest of the world. There are examples in Africa, but there are several issues that could be addressed and other technology that could be introduced. And there is a need of scaling up this model. Through the MOH, there is a plan that is ready. I left the budget ready. Now, I hope the political will continue. And we have to deal with the issue that political issue also affects whatever we do in health. And this new model for social business that we're looking for investors, I think will be another way of trying to address the issue. So the idea will be buy one test and help one rural woman or another woman to get the test, and so we can together say goodbye to cervical cancer. We're working also to see if we can have incentives for HOPE ladies. And I want to acknowledge Grand Challenges Canada and the National Council of Science and Technology that for the very first time has been giving funds for research in Peru. If you are interested, we have a video in which the women that help us are talking. It's in YouTube, and you can find it as HOPE Final. Should have been Final Hope, right? But the translation didn't work well. So you can find it in YouTube. But what I'm trying to bring you is there are things that we can do guys from the academia. But there are three things that we have to remember for things to be successful. So one of the things is whatever you do has to be evidence-based. The second thing, which is quite important, is coordination. And the fourth one is continuity. And I think in the 3 points, academia has an advantage, but we need to work also with governments. Thank you so much.
I'm so glad I was here to see what was revealed. It was one of the best pieces of real-time theatrical advocacy I have ever encountered, and I congratulate the Minister for it. I've already imposed on your time unduly, so I'm going to be both brief and somewhat scattered. My heart began to beat feverishly when Professor Volmink mentioned neoliberalism and how pernicious it is. I've spent my entire adult life fighting against neoliberalism, may I say with almost transcendental futility, but it's good to find someone else who thinks in roughly the same way. And when we talk about unfair distribution of goods and resources, I was just thinking of the sort of déjà vu quality of so much of our discussion, because on all of these questions of assets and products and distribution, the economist Amartya Sen has written and spoken in a way which is indelible and lasting, and if only one had ever paid attention to him, the world would be in so much better shape. I also thought, Professor Volmink, when you mentioned the World Bank and its pride in reducing extreme poverty by 1 billion, that it's worth pointing out, in case some hadn't noted, that almost all of that billion is China. Very little reduction in extreme poverty anywhere else. It's almost all China. And that allowed the moving from the rural to the urban areas, and that allowed the World Bank to offer this so-called insight without any adornment of how it happened. I was also fascinated with the emphasis on equality and inequality, because for the first time ever, equality was inserted into the Sustainable Development Goals. There was no equality goal in the Millennium Development Goals, which ran from 2000 to 2015. So equality, you see, was discovered in 2015. Now you have to fet the cerebral intellects in the world who run the planet that they did discover equality in 2015. I'll tell you something else they discovered in 2015: sexual and reproductive health. It was nowhere to be found in the Millennium Development Goals from 2000 to 2015, and suddenly there was this shock of recognition that half of the world had somehow been excluded, and maybe there should be a moment of incorporation. It's just fascinating to see how these things evolve and how they should be taken advantage of. The sad thing about South Africa, of course, is that it's now considered, one of my colleagues was pointing out to me, using the Gini coefficients, it is now reported as being perhaps almost the most unequal country in the world. And that's a sad commentary on the hopes and expectations that emerged when Nelson Mandela got out of prison. And while the Lancet Commission on Africa is an interesting document, there is absolutely nothing novel in it that hasn't been said by African scholars for God knows how long. And if you go back and look at Tony Blair's Commission on Africa of a decade or two ago, it said exactly the same things with very little impact. So it comes back to this very difficult conundrum that we're able to do objectively intelligent analyses of how to deal with these problems, but we don't have somehow enough energy to get them implemented, to get the powers that be to make the changes. And that, of course, is something that this constellation of people can do so nicely. When you mentioned Piketty, Professor Volmink, my mind went back to R.H. Tawney, who wrote the wonderful book on equality prior to the First World War. And again, nothing has changed from that day to this. I want to say something and then take my seat. I want to say it quickly, although it deserves hours. I mentioned in my remarks the patterns of sexual violence and assault that have become indicative and now chronicled in the international humanitarian community. Everybody is aware of what happened with Oxfam and Save the Children, and now increasingly in the United Nations. You will know that there is something called UNAIDS in the UN. UNAIDS is the coordinating body for all of the activities on HIV which are pursued by the family of UN funds, programs, and specialized agencies. So there are a dozen cooperating partners that belong to UNAIDS. UNAIDS is a very unusual and ill-defined hybrid, but of course it is entirely a health-directed organization. And those of you who have read The Guardian will know that the Deputy Executive Director of UNAIDS, a man who stands with the title of Assistant Secretary General of the United Nations, who was appointed to his position by the present Secretary General, Antonio Guterres, you will know that a very strong complaint was lodged against Luis Lours, the deputy at UNAIDS, for a sexual assault. It became one of a number of stories over the last few weeks, but perhaps the most vivid and dramatic of all because of his very, very high status in the organization. There was an investigation, so-called, into the assault or the claim of the assault by the claimant, and ultimately Luis Lours was exonerated by an investigation which those of us in Code Blue understand was hapless in content and in execution. It was an offense against serious investigations, and it demonstrated, as is so often the case, that investigations in the multilateral system are designed to exonerate the perpetrator and to demonize the victim. In fact, it can be said that the United Nations system may be the only part of the international panoply of organizations which has not yet learned the meaning of Me Too or Time's Up. The damage control mechanisms are so intensely in place that all of that can be, all of the reality the rest of the world putting up with can be forestalled within the UN. So it's a very difficult thing to come to grips with, which my colleague, as I said before, Paula Donovan, and I and our other colleagues in Code Blue are trying so hard to confront. Now, we have made of this a pretty serious issue because something happened which was painful and very, very difficult. The executive director of UNAIDS inappropriately inserted himself into the investigation in ways that utterly compromised the entire process, so that the people right at the top were judging each other. And everybody who was supposed to be providing information were people whose jobs were dependent on the people at the top who were under investigation. It was an impossible little cauldron of hypocrisy and self-indulgence. And as a result, there is an increasing clamor about what happened in UNAIDS as an example of what's gone wrong in the system. And for us, and I mention this because it's so interesting, because this is a health organization engaged for heaven's sake in dealing with the pandemic. How would you have sexual misconduct at the highest level of UN AIDS of all places. It doesn't make any sense, and no one is acting on it. Everyone is avoiding it within the UN system and amongst the member states, because no one ever wants, in multilateralism, to confront these things, and women are always, therefore, demeaned and discarded. It's really a rupture of integrity and reputation. And the problem is that the entire UN system is submerged in a conflict of interest. That's what Paula Donovan and others have made a point of, that the UN system is defending the institution, is defending the perpetrator, and is supposedly defending the victim. And you can't be judge and jury of everything. It doesn't work. The conflict of interest is too great. You can't pretend that you're going to defend employees on both sides of the dispute and the institution as well. So you never get an honorable resolution. And we have therefore said, I think with some intelligence and legitimacy, that it must be taken completely out of the hands of the UN, that there should, in the immediate present, have an emergency panel which follows every single episode of sexual violence across the UN system, from the moment of reporting to the moment of disposition, from the outside, independent, looking at what is happening in real time, so that if anything goes off the rails, it can be corrected. And then, in the longer term, you set up some kind of special court mechanism to look whether it's peacekeeping operations or whether it's the agencies. So it's been a, Paul, I was thinking it's been an amazing experience over 3 years to watch how hard it is to put together an argument which will be accepted by member states, which can bring the United Nations to its senses, which can allow women to feel free to come forward, not so terrified of losing their jobs. I wish I could show you the transcripts of the interviews that were taken in the case I've mentioned. It would freeze your blood. It's just unbelievable how wrong they were, but in truth, you can't tinker with it. You can't fix these things by playing around. You have to take it out of the conflict of interest and bring it into the arena of an independent, neutral, external assessment. That's the way things best work. And I want to say to all of you that if you want to see inequality in the health system, take a look at what is happening with sexual misconduct and UN AIDS. It is painful. Thanks.
Hi everyone. I think that we will use the few minutes to have some questions from the audience, some discussion. Mary might come back, but we're not sure. So if she does come back, she'll continue her presentation. But in the meantime, are there any questions from the audience? Okay, can we start with the lady on my right there?
Yeah, can you hear me okay?
Yeah.
Well, I wanted to thank the panel for a wonderful presentation across the spectrum of issues related to social justice and health. Obviously, they're inextricably linked. I wanted to ask Dr. Garcia, hi, Dr. Garcia, this is Nimi Ramanujam from Duke University. I'm very committed to cervical cancer prevention, and also we're working in Peru. And one of the questions I have is, yes, goodbye cervical cancer with HPV, but what about the challenges with the care cascade and how women actually go through that process? And also, how can we empower women to be in the community to really make a difference if there are challenges with giving them that, empowering them with that responsibility because of issues of, how shall I say it, being territorial and not allowing this ability to task shift in a way that would have the greatest impact on women that are disproportionately affected by the disease.
Thank you for that question. I see two other people, so maybe I should just take the two more questions and then we'll try and...
Good morning. Thank you, panelists, for that presentation. I want to specifically talk about the presentation of Jimmy. Hi. Thank you for the elaborate presentation, especially with the focus on Africa, the disparities in Africa. So personally, I'm committed to the geriatrics, that population, the aging population in Africa. So my name is Amara Francis. I'm a nurse from Nigeria. In a few minutes, I'll be presenting one of our findings in the disparity in health in aging population in Nigeria. So there is a big gap in that population. So I want to ask, you know, you made a particular, you pointed out some statistics, but it was coming from South Africa. You said that of sub-Saharan African is not that obvious. And I hope with research that we are doing, we'll be able to bring out this data. So for this population, I want to know what is the intervention, what are the strategies? The major question you raised concerning this panel is about how we bridge the gap in universal health coverage. So you say one of them is engaging stakeholders, and that is what I'm doing. I have to, so I really need more people to come out to work with me, to go to these stakeholders, because National Health Insurance Scheme is a platform that African countries can use to bridge the gap in universal health coverage. There's a lot of money that is stashed in that place. Using Nigeria as an example, the Secretary of National Health Insurance Scheme has said that less than 30% of the population of Nigeria is covered by National Health Insurance Scheme, yet a lot of money goes there, and that is also happening in a number of African countries. So if we can engage the National Health Insurance Schemes of countries to enroll people into that program, I believe it could actually help, and especially for the aging population, that could actually help us bridge the gap for that population. So I'm very much interested in that, and I want to know more about what the health community is doing about geriatric population, how to bridge the gap in their health care. Thank you.
Thank you. And then one other question.
Yes, thank you. I thought that the talks were very fascinating this morning, and one of the common themes that I've been hearing through the thread is that funding is one of the fundamental problems that people are facing when they have these really great ideas for research. I'd like to point out, I'm from Monsanto, which is one of the world's most beloved companies, and I would like to actually encourage people to pay attention to Sustainable Development Goal number 17, which is partnerships, and not throw the baby out with the bathwater when it comes to industry partnerships. Because remember, Rockefeller, Carnegie, and Gates all started with industry, and I would encourage everybody to, I'd like to hear your comments on that, because I think actually great good can be done in partnership.
We struggled to really hear very well what you were saying. So you wanted to comment on what specifically? Can you just repeat that? None of us could hear very well.
What was the question?
Yeah.
The question is that Sustainable Development Goal number 17 emphasizes partnership. And funding seems to be one of the difficult things that people have in achieving these great ideas. And I want to make sure that people understand that industry is an important partner there. And if you think about Gates, Rockefeller, and Carnegie, those foundations all came from industry. So I'd encourage people not to throw the baby out with the bathwater, and I'd be curious to know how you would plan, what your plans are for funding some of these really wonderful ideas.
Thank you. Just before we ask the panel to respond, I have been asked to just tell you all that at the end of the session at 10:45, Thomas Quinn has got a surprise. So please don't leave immediately after the session. Just stay for a couple of minutes. because Thomas Quinn will come up and surprise you all. So I have no idea what that means. We've had lots of surprises already this morning. Yeah. All right. Would you like to start?
Well, first of all, thank you so much for the questions. That allows me to go over the 10 minutes. So, first of all, about the care cascade. So, I have to tell you behind the scenes that when we started the implementation of the study, we were not really aware of all the difficulties. I mean, so we knew that there were difficulties, but they were even worse. So in this area that I was talking to you of about 2 million people, there was no OBGYN and nobody doing colposcopies at all. Although there was a network of 15 health centers, 14 health centers, and a hospital. So since we wanted to be sure that every single woman that was found to be positive had care, we had to work together with the health direction, the local health direction, and actually we had to fight several things. And this experience was really helpful for me months later, becoming a minister. So one of the very important things in general is that we don't have enough training physicians, as happens in different parts of the world. And we didn't have enough OBGYNs. Plus, if we had an OBGYN, he will not do colposcopy in the public sector. He will be doing it in the private sector. And so that means that if a woman has a little bit of money, she could pay for it, and corruption starts. I mean, as part of what I mentioned, all these weaknesses in our institutions. So one of the things, and we did an additional study in the area of Ventanilla. What we did is we reviewed all the pap smears that were taken 2 years prior to that, and we found that there were about 15,000. And from those 15,000, we identified all the ones that were positive, abnormal. And from all the abnormal, we identified all the ones that were high grade and that definitely needed some type of management later on. And the thing is that, and this is a paper that is coming, what happened is that we documented that it was about only 20% of the women that were having high-grade lesions. And I'm talking about lesions that, like in situ cancer or cancer, CIN3-2, that only 25% got eventually treated. I'm not talking even about a good treatment, okay? So the care, the cascade, is another thing that needs to be worked on, and as part of the new guidelines, and that goes into the second question that you were asking, about task sharing and task shifting. So one of the things that we realized is that we needed to do something, and within the project and then outside as part of the guidelines, we have included the possibility of midwives, because we have professional midwives, to be trained in colposcopy and to do colposcopy, so see and treat. And that's now in the guidelines. But that cost me a huge fight with health professionals, especially with OBGYNs, because they are making a lot of money. And actually I had a very interesting meeting, and it was talking about discrimination and all those things. This was an incredible meeting because it was my lawyer, well, because you always work with a lawyer when you're a minister. Actually, it was the Secretary General, the Vice Minister of Health, and me, 3 women and 10 men, all from the Society of OBGYN and Gynecology. And so first they were telling me all these stories about why midwives, professional midwives, who study 5 years, and a 6th year will be for the colposcopy, cannot be doing colposcopies. And then at the end, they said, plus, how do you think we are going to live? First, you're taking with new technologies, we're not gonna be doing pap smears. which is one of the most important ways in which we get resources. And the second is now you're putting somebody else to do what we are doing. And actually, we don't have enough physicians. So I think the war is not over. The guidelines are there, but there is a lot that needs to be done. And these words, task shifting and task sharing, interestingly, I couldn't find nowhere in any of the guidelines of the Ministry of Health of Peru those words. So I have to create a translation into Spanish and start talking about it. And actually, that's one of the problems that we're having also, is the fact that there is a lot of jealousy and there are powers associated with it that create more inequities. That's what I was bringing, and I hope you got this discussion that we just recently have at WHO, because I think it's quite important that an institution at that high level starts to talking about breaking those powers, okay, and bringing people, the community and the people, I'm not talking about patients, I hate the word patients, okay, into the scene of health, having a continuum in which the user can initiate the intervention. Maybe that's not going to be the final word. We're discussing what could be the best one. But so in a way, in this continuum, we are also task sharing and task shifting, but even into the community. So I think there is a lot to do. The guidelines at least are considering already people involved. They're considering midwives to be able to do colposcopies and to treat even cryotherapy. We have a plan for 7 years to buy colposcopes, cryotherapy, still a problem, and we are trying to look into, somebody talk about partnerships. Yeah, we had some partnerships with, for example, with Hygiene for HPV. We were in these negotiations, and we got a very good price for the test, with the idea of trying to scale it up in the country. But also we're talking with universities because we need new technologies to make things simpler. Cryotherapy with CO2 is difficult to be used in rural areas or areas that are far away. But now there are people that are talking about new technologies like using alcohol as a way, injections of alcohol as a way of treating. The same way, we need colposcopes that could be much simpler so they can be used anywhere in the country.
Thank you,
and that's it.
Thank you very much. I'm going to be very brief on the issue of the elderly, and I'm going to ask, you can talk about the partnerships too. So the issue of the elderly in Africa is of course very, very vexing, because older people do have a very hard time. Very often they become the primary caregivers in families where lives have been lost through HIV/AIDS and so forth. But the issue of the care of the elderly is not high on the agenda. Africa is a very young population, and there are many other issues. It reminds me a little bit of the fight to get chronic non-communicable diseases on the agenda in Africa. When I returned from the UK in the early 90s back to South Africa, and I had done work on cardiovascular disease, I wanted to continue that in South Africa, and I was laughed out of the door because people said, this is not a problem, it's infectious diseases you've got to focus on. And it's the same kind of situation. I think it's a case of continuing to motivate, to advocate, to work with civil society, with the healthcare sector, and with the politicians to try and drum up support for that. I think it will take time. Stephen, would you like to comment on...
I'm just a little self-conscious because there are people at the mics I see, Wafa.
We're pretty much out of time.
You're out of, okay, well, then if we're out of time, as time slowly dies in the presence of this vast ensemble, let me just make the point that I don't think people should be traduced into the assumption that the private sector and major businesses are really willing in significant ways to contribute to global health. There are some. There are obviously some moments when that's the case, but for example, the Global Fund on AIDS, Tuberculosis, and Malaria has been for years begging the multinational corporations to contribute, and with the exception of the Gates Foundation, which is in a separate category, there is, to my mind, there are only 2 or 3 very, very modest, so modest as to be embarrassing, grants to the Global Fund from the corporate world. By the way, I have not noticed a grant from Monsanto. And I think it's also worth noting that number 17, target 17 of the Sustainable Development Goals indicates very strongly that far more is going out of the countries in the developing world than is going into the countries. The loans from the international financial institutions, which attract a certain interest rate, result ultimately in far more money coming out than going in. And where is much of that money going out from? It's going into the coffers of multinational mining corporations and others. So it's necessary to be pretty careful about assumptions around a continent like Africa. They may be receiving a lot of official development assistance, but any analysis of World Bank or IMF figures will show you that 3 to 4 times more is leaving those countries than is going into them for purposes of development. That's a painful truth.
Thank you. Unfortunately, we are out of time, and I have to give time for the surprise that we promised you. So I'm going to have to bring this session to an end. I hope that you have found it to be interesting and beneficial. I want to thank the speakers for their contribution. I think we can continue this discussion, the engagement over tea, but also in the other sessions that will follow. So thank you very much to all of you.
Good morning. I don't know that this is as much a surprise as it will be a celebration. Every annual meeting, we recognize one of our members with a series of our awards. This is the Tom Hall and Nelson Sewangkambo Mid-Career Leadership Award. And really, it's appropriate that this award is given to this individual after this plenary, which was so engaging and so close to what we are all about at CUGH. So as we contemplate the discussions that we just had on the world of disparity and the potential solutions to inequities that are so prevalent throughout the world, we honor this one individual who's trying to make a difference. And each of us in our own way try to make a difference. She's been phenomenal in how she has led her programs in Swaziland to make a difference in the field of HIV and tuberculosis. This year's awardee for the Mid-Career Leadership Award is Dr. HARRIET NUWAGABA-BIRIBONWOHA. She is a Ugandan. She is a Ugandan who we wish Dr. Nelson Sewangkambo, another member of CUGH, was here to present this award because it's so meaningful, named after him and Tom Hall. But let me just tell you a little bit about HARRIET. Born in Uganda, she received her medical degree from Makerere University in Kampala in 1999. She was then named a Rhodes Scholar in 2001 and obtained her PhD in epidemiology from the University of Oxford in 2005. Upon her graduation, she returned to Uganda and practiced medicine and joined the Medical Research Council and took on a research career working with the Clinical Trials Unit in London and leading programs and educational programs in implementation science. It was in 2009 that ICAP here at Columbia recognized her expertise and hired her as an assistant professor in epidemiology, and she served as director of ICAP for monitoring and evaluation in Tanzania, and then subsequently in Uganda, and more recently, 2013, in Swaziland. She leads a program staff of over 200 researchers, developed a course on implementation science taught at the Mailman School of Public Health at Columbia University, and has mentored many students. What is unique and was heralded as one of the big successes in the field of HIV/AIDS in Paris just last year was that she led the 2016 Swaziland population-based HIV impact assessment, we call it FIA, which demonstrated for one African country a remarkable reduction in incidence of HIV by 50%. Now, that took the whole country to do that, but she was one of the enablers who led many of the individuals that led to this dramatic decrease in HIV, something that is now being replicated as much as possible throughout other African countries. So with that, will you please congratulate HARRIET NUWAGABA-BIRIBONWOHA for the Mid-Career Leadership Award. HARRIET? CUGH has, with this award, given a beautiful crystal ball of the globe. and I've been told not to tilt it or it will roll out. Congratulations, and we wish you all the best. Thank you. You can now go for coffee and see if the protests are still going on.